Retinoblastoma is the most common intraocular childhood malignancy. Despite prolonged and concerted efforts in conquering it, a major challenge in eye and vision salvage is the persistence or recurrence of vitreous seeds in advanced retinoblastoma. Vitreous seeds are considered as endophytic proliferation of large undifferentiated tumors which may exist as loose, cohesive or clumps of viable tumor cells floating in the vitreous. Clinically, they appear as waxy to white fluffy seeds of variable size or clumps of loose cells distributed focally or diffusely in the vitreous. They may persist in the hypoxic environment of vitreous cavity despite complete regression of the retinal tumor and are often resistant to systemic and periocular chemotherapy. Apart from tumor implantation on the retina, these seeds can migrate to the anterior segment, seeding the ciliary body, angle structures and iris with consequent risk of systemic dissemination. Systemic intravenous chemotherapy fails to achieve significant concentration in the vitreous across the intact blood-retinal barrier into the avascular vitreous body. Other recent techniques including supraselective intra-arterial chemotherapy and periocular delivery of the chemotherapeutic agents have shown improved but limited success. Perhaps the optimal way to achieve desirable therapeutic concentration where it matters is the direct injection of the chemotherapeutic agent in the vitreous cavity. However, the classic teaching is to avoid intraocular procedures in retinoblastoma because of the potential risk of extraocular tumor dissemination. It has been recently demonstrated that intravitreal chemotherapy in retinoblastoma can be safe and effective if the injection technique is suitably modified and target cases are carefully selected. Recent introduction of direct intravitreal administration of chemotherapeutic agents has shown promising results. Currently, the most commonly used intravitreal chemotherapeutic agent is melphalan. Topotecan hydrochloride, which is known for its low toxicity profile, is also found to be effective, and there is enthusiasm to use it. Indications for intravitreal chemotherapy are persistent vitreous seeds after primary intravenous systemic chemotherapy or intra-arterial chemotherapy, recurrence of vitreous seeds after completion of treatment, and chemoresistant vitreous seeds. Contraindications include seeds dispersed diffusely in the entire vitreous cavity, anterior segment and/or ciliary body invasion, secondary glaucoma, high bullous retinal detachment, vitreous hemorrhage obscuring the fundus view. Careful preoperative evaluation and meticulous documentation of the type and location of vitreous seeds is extremely important. The retinal source of vitreous seeds should be identified, if any, and treated appropriately, as it may continue to shed seeds. Pars plana examination should be performed entire 360-degree to ensure absence of tumor or seeds at the intended location of injection. It is preferable to choose a site at least 2 clock hours away from the tumor location. After reconstitution of the drug to a dosage of 20 microgram per 0.1 ml under sterile precautions, the tuberculin syringe is transferred to the surgical field. Melphalan has a very short half-life and it is recommended to use it within 1 hour of reconstitution. The eye to be injected is confirmed prior to the injection. The fundus appearance is documented with wide-angle imaging and the exact location of the injection confirmed by a careful indirect ophthalmoscopy. Hypotony is achieved by applying gentle pressure over the eye for a few seconds. Under aseptic precautions, the eye is draped. After placing the lid speculum, pars plana is marked at an appropriate distance away from the limbus. Age-based method was used to determine the safe site for injection as follows: 1.5 mm posterior to the limbus in those aged 1 to 6 months, 2 mm in those 6 months to 1 year, 2.5 mm in those 1 to 2 years, 3 mm in those 2 to 6 years, and 3.5 mm in those above 6 years of age. Under the guidance of operating microscope, a 32-gauge needle mounted on the tuberculin syringe is introduced into the center of the vitreous. The needle is steadily held in place and appropriate dose is injected gently. A 3 mm cryoprobe is applied to the puncture site with the needle still steadily held in position. The needle is withdrawn through the consolidated ice ball that forms around its base, thus precluding fluid reflex through the puncture site. Triple freeze-thaw cryotherapy is performed at the injection site. Eyeball is jiggled for the even distribution of the drug in the vitreous. Antibiotic cycloplegic ointment is applied and the eye is patched for the night. Postoperatively, topical steroid, antibiotic and cycloplegic drops are typically used for 3 to 7 days. The injections are repeated every 1 to 4 weeks to a maximum of 6 injections until complete response is documented. Regress vitreous seeds may appear as refractile or calcified residues and may even completely disappear. Following complete response, it is advisable to administer one more injection for consolidation of subclinical viable tumor cells in the vitreous. Reported complications associated with appropriate doses of intravitreal chemotherapy are minor and include retinal pigment mottling at the site of injection and focal vitreous hemorrhage. Whereas, the reported eye salvage was as high as 100% after intravitreal melphalan hydrochloride. Having achieved nearly 100% survival of children with retinoblastoma, by protocol-based management, the current focus is to optimize eye and vision salvage. Intravitreal chemotherapy is a promising technique performed worldwide for combating resistant vitreous seeds in advanced retinoblastoma, thus avoiding external beam radiation and enucleation. The demonstrated safety-enhanced technique of intravitreal injection is devoid of any major risks and is effective if performed with caution in a carefully selected subset of patients.